Welcome back to the Deep Dive. We're here again, ready to cut through the noise and give you the essentials from complex sources. Today, we've got a really specific mission. One of you actually sent us some clinical revision notes, so we're going deep on those,
That's right.
pulling out everything high yield, everything you absolutely need to know.
Exactly. Think of it as targeted revision.
Yeah, perfect if you're prepping for something like the MSRA or, honestly, just want to get a really solid handle on a common clinical issue. We are sticking strictly to these notes.
We are. And the topic, based on this material, is postcoital bleeding. PCB for short.
PCB, okay.
We'll break down what the notes say about, well, everything. Definition, causes, investigations, management, the lot.
Right. Our mission, distill these notes point by point, highlighting what you need for understanding, for recall. Let's jump right in. Okay, so first things first, definition. According to these notes, what exactly is postcoital bleeding?
Okay, so the notes are quite precise here. PCB is defined as vaginal bleeding that happens after sexual intercourse.
After sex. Got it.
But crucially, two key things are highlighted. One, it's non-menstrual, so it's not part of a normal period.
Right, separate from the cycle.
Exactly. And two, it typically happens immediately after sex.
Immediately after non-menstrual.
Okay. And the notes, helpfully, I think, contrast this with other types of unscheduled bleeding. They mention AUB, abnormal uterine bleeding, which is sort of the big umbrella term.
Okay.
And under that, you've got things like intermenstrual bleeding, IMB, which is bleeding between periods,
Right.
and breakthrough bleeding, which you often see with hormonal contraception, irregular bleeding.
Makes sense.
But the really important point the notes make is that PCB and IMB are symptoms. They aren't diagnoses in themselves.
Oh, okay. That's a key distinction.
Yes. They're red flags. They
Yeah.
signal something might be going on. And because they can, raise concerns about cancer, they always need looking into.
So getting that definition crystal clear is step one.
Mhm.
Non-menstrual, immediately after sex. It kind of narrows the focus straight away, doesn't it?
It really does. The notes even mention things like the FIGO guidelines, updating terminology for AUB, just reinforcing how vital clear definitions are.
So for your memory hook here, PCB, after sex bleeding, not period related, lock that in. All right. We know it is. Why does it happen? What are the causes of PCB according to these notes?
Well, this is where it gets really interesting. The notes kick off this section with a pretty striking fact.
Oh, yeah.
Yeah. In about 50% of cases, half, no identifiable pathology is found.
Wow. Really? Half the time?
Half the time. You do the workup, the investigations, and you just don't find a specific disease or structural problem causing it.
And it's unexpected.
Yeah. Now, for the other 50% where you do find a cause, the notes list the common ones specifically for PCB.
Right. What are they?
Okay, so common causes listed are cervical ectropion.
Ectropion.
Cervicitis, that's inflammation of the cervix, and they specifically mention chlamydia as a common cause of that.
Okay. Infection.
Yep.
Then there's cervical cancer, unfortunately. Cervical
Yes.
polyps. And trauma, injury from intercourse itself.
So ectropion, infection like chlamydia, cancer, polyps, trauma.
Those are the main PCB-specific ones listed. The notes do mention other causes for IMB or breakthrough bleeding, like pregnancy issues, hormonal contraception side effects, uterine fibroids, stuff like that. But for PCB, focus on that core list.
Got it. The 50% no-cause figure is definitely one to remember. It probably helps manage patient expectations too, right?
Absolutely. And for remembering the causes, maybe that list. Ectropion, infection, chlamydia, cancer, polyps, trauma, EICPT, something like that.
The ICPT might work. And always keep that 50% no-cause found in mind. Okay, so moving on. Who's more likely to get PCB? What are the risk factors mentioned?
The notes list a few key things. Things that increase the risk include having a history of infections, cervical or vaginal ones.
Okay, past infections.
Previous trauma to the cervix or vagina, certain STIs.
Yeah.
And any known abnormalities of the cervix or vagina.
So these are basically your pointers during history taking. Exactly. Key questions. Any previous infections, trauma, STIs, known cervical issues. They help narrow down possibilities.
Right. Let's get a bit more technical. How is the bleeding actually happening? What about the pathophysiology?
Well, the notes are clear. It really depends on the underlying cause. There's no single mechanism.
Okay, so it follows the cause.
Precisely. The general processes mentioned are things like inflammation, infection causing fragile tissue, direct trauma tearing something, or abnormal cell growth, like in cancer, that bleeds easily.
So if it's cervicitis, it's inflammation making it bleed. If it's trauma, it's a tear. If it's cancer,
It's the abnormal tissue itself being fragile and prone to bleeding on contact. The how directly links back to the why, the cause we just discussed.
Makes perfect sense. Understand the cause, understand the mechanism.
Okay.
Differential diagnosis time. Someone comes in with bleeding after sex. We know the likely PCB causes, but what else should be on our radar? What else could it be?
Good question. The notes really stress differentiating PCB from other types of bleeding. So the differentials include, could it actually be related to the menstrual cycle, like spotting just before or after a period?
Right, timing is key.
Definitely. Could it be coming from higher up the uterus or endometrium? Things like fibroids, endometrial polyps, or endometrial hyperplasia, which is thickening of the lining.
Uterine causes, okay.
Vaginal infections that might cause bleeding independent of intercourse, hormonal imbalances causing irregular bleeding patterns, and importantly, cervical or vaginal cancer needs to be actively considered and ruled out, even though it's also a primary cause of PCB.
So it's both a cause and a crucial differential.
Exactly. You have to be sure you're not missing it.
So the thought process is this really PCB? Or is it uterine, vaginal, hormonal, cycle-related? God cast the net wide initially.
Precisely.
Let's talk numbers. How common is this? What does the epidemiology section say, particularly for the UK?
The notes say UK-specific data is a bit limited overall, but they give a prevalence range for menstruating women somewhere between 0.7% and 9%.
0.7 to 9%. So quite a wide range, but not vanishingly rare.
Not at all. And there's a specific UK study mentioned that looked at perimenopausal women.
Right. What did that find?
Over 2 years, the cumulative incident, so the number of new cases developing was about 8% for PCB in that group.
8% in perimenopausal women over 2 years.
Yeah. And perhaps even more interestingly, that study noted a spontaneous resolution rate of 51% for PCB in those perimenopausal women during that time.
Wow, over half resolved on their own.
Seems so in that specific group and time frame. The notes do reiterate, though, that any unscheduled bleeding causes anxiety because people worry about cancer.
Understandably.
Absolutely. But the notes sort of gently point out that while the anxiety is real, the actual link to cancer, especially in groups like perimenopausal women, might not be as strong as feared, and the spontaneous resolution is quite common.
That's really useful context.
Yeah.
It's common enough to see regularly, causes significant worry, but often resolves or has a benign cause. Good to know. Okay, let's get practical. Someone presents with PCB. Walk us through the clinical approach based on these notes. History, exam.
Right. The notes describe the basic presentation. Bleeding right after sex. Could be light, could be heavier. But the real detail is in the history and exam.
Okay, what's crucial for history?
Thoroughness. The notes list. Full menstrual history, regularity, flow, dates. Obstetric history, past pregnancies. Gynecological history, really important here, are cervical smear history and current contraception.
Smears and contraception, critical.
Got it. Sexual history, to assess STI risk. Any relevant medical history, like known bleeding disorders or diabetes, and what medications they're currently taking. You really need to cover all those bases.
That's comprehensive. Okay, then the examination.
First, confirm the bleeding is vaginal. Check BMI, remember. It's a risk factor for endometrial cancer. Abdominal exam for any masses. Then the pelvic exam is key. Speculum first, then bimanual. You're looking closely at the cervix. Where's the bleeding coming from? Does touching the cervix make it bleed? That's contact bleeding. Is the tissue friable, meaning does it tear or bleed easily? What does the cervix look like overall? Is there any abnormal discharge?
And what might you see?
The notes mention common findings like seeing an ectropion, finding polyps, or observing signs of cervicitis redness, discharge.
Okay, so for anyone listening, if you're revising this, picture that clinical encounter. What are those key history domains? What are you specifically looking for on that speculum exam? Think practical checklist.
So, history and exam done. What investigations follow? What tests do the notes recommend?
Okay, investigations pathway. Number 1, always rule out pregnancy. So a pregnancy test first.
Always. Okay.
Then an infection screen is essential, especially checking for chlamydia.
Makes sense given it's a common cause.
Exactly. Yeah. Check if cervical screening, the smear test, is up to date or overdue.
Then you might move on to blood tests. The notes mention full blood count, FBC, maybe clotting studies, thyroid function tests, TFTs, and potentially FSH-LH levels if you're thinking about menopause.
Okay, blood's covered. What about imaging or other tests?
Transvaginal ultrasound is often key. The notes say it's ideal for looking at the pelvic structures and best done just after a period finishes, if possible.
Ultrasound. Okay.
If there's concern about the uterine lining, particularly based on age or risk factors or ultrasound findings, an endometrial biopsy might be needed. The notes mention the Pipel device, which is commonly used for this in an outpatient setting.
Pipel biopsy, got it.
And critically, colposcopy, that's a magnified look at the cervix, is recommended if the PCB is persistent.
Persistent PCB triggers colposcopy.
Okay, and this ties into the referral criteria, which are really important. When do you need to send the patient for specialist review?
Yes. What are the key referral flags?
Yeah. The notes list several. If the cervix looks suspicious on examination, if you see polyps that seem difficult to remove or look unusual, if there's a pelvic mass felt or a significant abnormality on the ultrasound.
Right.
Also, patients with high risk factors for endometrial cancer, like a strong family history, very irregular cycles, or if they're taking tamoxifen.
Okay. High-risk individuals.
Age is also a factor. Women aged 45 or over with any new IMB, intermenstrual bleeding, or women younger than 45 if their symptoms are persistent or they have other risk factors.
Persistence again.
Yes, and this is crucial even if you've done the initial assessment, history, exam, maybe basic tests, and you haven't found an obvious cause for the PCB, but it's still happening. That persistence itself is a reason for referral.
That's a really important take-home point. No cause found, but persistent bleeding still warrants referral.
Definitely. And there's another note mentioning bleeding lasting over 3 months, particularly if it's heavy, should prompt further evaluation.
Okay, so investigation flow. Pregnancy infection first. Then structural checks like ultrasound, maybe biopsy. Persistence or red flags mean referral or colposcopy. Need to know those referral criteria. Right, we've investigated, maybe found a cause. How is PCB managed? What are the treatments?
Unsurprisingly, the notes stress this again and again. Management depends entirely on the underlying cause.
Tailored approach.
Completely. So if cancer is suspected, the absolute priority is urgent referral to specialist services. The notes mention NICE guidelines highlighting postmenopausal bleeding as a key cancer sign, just reinforcing that urgency if malignancy is suspected with PCB, regardless of age.
Okay, suspected cancer, urgent referral. What about other causes?
For infections like chlamydia, it's antibiotics. And importantly, partner notification and treatment. For chronic cervicitis, sometimes linked to things called Nabothean follicles, the notes mention electrocautery as an option.
Okay, infection sorted. What if it's related to hormones?
If it's linked to hormonal contraception, first step is counseling warn patients starting hormones that some irregular bleeding is common initially. Check they're taking it correctly, check for drug interactions.
Right.
If the bleeding carries on for more than 3 months, a speculum exam is needed. And if the woman is 45 or older with persistent bleeding on hormones, an endometrial biopsy should be considered. The notes also detail strategies like trying different combined pills or potentially adding other medications short-term for some types of hormonal contraception bleeding.
Okay, specific strategies for hormonal causes. What about ectropions?
Cervical ectropions might resolve on their own, like after stopping the pill or post-pregnancy. If they don't, or if they're very symptomatic, treatment usually involves cauterization using silver nitrate, heat, or cold therapy to treat the delicate area.
Cautery for ectropions. Polyps.
Cervical polyps are usually removed and sent for histology, just to be sure. The notes mention endometrial polyps in reproductive age women generally have a low cancer risk.
And fibroids.
Depends on size and location. Smaller ones might be removed hysteroscopically, scope via the cervix. Other options include uterine artery embolization, UAE, to cut off blood supply, medical treatments to shrink them, or surgery for larger ones.
Lots of options depending on the finding.
Exactly. And it's worth remembering that point about higher spontaneous resolution in perimenopausal women might support a watch-and-wait approach initially if serious pathology is ruled out.
Good point. So management, find the cause, treat the cause. Simple in principle. What about the long-term outlook? Prognosis.
Again, entirely dependent on the cause, according to the notes.
Predictable.
Yes. For benign causes like ectropion or infection, once treated, the outcome is generally excellent. For cancer, prognosis varies hugely depending on the type and stage at diagnosis.
Makes sense. And finally, complications. Anything to be aware of?
The notes are brief here. For benign causes, complications are generally low risk if managed properly.
Good.
For cancer, the complications are related to the disease progressing, potentially spreading, or side effects from the cancer treatment itself.
Right.
But the notes wrap up this section with a really key message. Early diagnosis and appropriate management are crucial for minimizing complications, whether the cause is benign or malignant.
Underscores the importance of the whole process we've just discussed. Wow. Okay. That was a really thorough walkthrough of postcoital bleeding, all based on those revision notes. We've hit the definition, The causes, including that surprising 50% no-cause statistic, the risks, the mechanisms, differentials, how common it is, the absolute must-dos for history and exam, investigations, referral triggers, management strategies for different causes, and finally, prognosis and complications.
Yeah, working through it systematically like this really shows how you approach a symptom that can range from, quite trivial to potentially very serious. It highlights why being thorough is so important.
Absolutely. And here's something to maybe chew on after this deep dive.
Okay.
Given that PCB is relatively common, it causes significant anxiety because of that cancer worry, even if the risk is often low. And half the time we don't find a specific cause, plus it often resolves spontaneously.
Mm-hmm.
How do we strike that balance in clinical practice? The balance between being thorough enough to rule out serious stuff versus avoiding over-investigating or over-medicalizing something that might just be benign or go away on its own.
That's a really key clinical dilemma, isn't it? There's no easy answer there. It's about clinical judgment, risk assessment, patient factors.
Exactly, something to mull over.
And having structured, high-yield info like these notes we just dissected is, well, invaluable for making those judgments, whether you're revising or actually seeing patients.
Couldn't agree more. And if you did find this focused deep dive helpful, especially if you are revising for exams like the MSRA, you might want to check out resources specifically designed for that, like PassTheMSRA.com and FreeMSRA.com.
Good shout. They offer structured learning and practice questions.
That's PassTheMSRA.com and the free resources at FreeMSRA.com. Right, that wraps up our deep dive on postcoital bleeding. Keep digging, keep learning, and we'll catch you on the next one.